first be widely based on what I've had in my first presentation when we think about prevention. It's good to see that theoretically what can we perhaps prevent of those individual and other risk factors. And we can't change our age, our anthropometrics, and practically not our sex. So that's something that we have to be accept as given. Then there is health status. Of course, we can manage many chronic diseases, and so it's possible to help people with that respect, but with many musculoskeletal disorders, for example, that are related to degeneration or living habits, it's not so beneficial as it was thought beforehand. When we look for the science literature on and those systematic reviews about treatment, they are not too promising. Then comes the health behavior. That's probably something that we can change. Personality, I don't believe. Coping strategies, that might be sometimes possible to change, and it's highly dependent on our ways of thinking, but not always. But something that we can change at workplaces, and what was also here in the multifaceting program in the previous presentation, is training. Competence is something that we can improve to do our work so that we don't take additional extra risks for health. Then comes, of course, those risk factors at work. Physical demands, they can be changed. It might be even sometimes automation. Technology has changed very much our work, but we have to keep in mind, of course, that there are still today many workplaces that don't have means enough to make really big changes. Work organization is possible to change. Is that, for example, I had one of the first studies I did, scientific studies I did about the patient handling in geriatric hospitals in Finland. And then we noticed that the way the hospitals were doing it, that they had a very real rush hour in the early morning, because they wanted to get all the beds done and all things so that they could be ready at 10 or 9 o'clock in the morning. And after that, the nurses, they were mostly waiting for that what will happen next. So it in that case there was the tradition comes from the hospitals where there are specific treatment, surgery, medical treatment, specific medical investigations, but they are not necessary in the elderly hospitals usually. So that's one example of those that we can change organization. There are plenty of other examples as well. And also we can change tools, equipment, technology, environment. For example, in the building industry, it's hammer in the professionals use hammer very seldom. They have equipments that are much more effective and much less loading than the usual hammer for nailing. Then comes one question, is this enough? And I say no. As I showed that the the whole complex picture is highly dependent on different players in this arena, and external societal system is social contracts, laws, and those that might be possible to change those, but it's usually quite a low way. And it's also that even though that we may get laws and orders, it's not guaranteed that people will implement those ways of doing things exactly that was meant. For example, we had in Finland a couple of years ago a new law that said that after 90 days of sick leaves, the occupational health services, because we have all workplaces should be covered by occupational health services, they should have an investigation that what can be done at workplaces to stop the prolonged sickness absence. And we were looking at, and we noticed that it was finally just after 9 months, the legislation has come out that it was fulfilled in some 20% of the occupational health records in the national insurance company. Then what we can do is we can manage cooperation within those different players, and we had a very nice study. Also, we did was to describe that what happened in Finland, in a city where they had changed their management for disabled people. So, and we heard that they had good results there, and we were interested in that what has been happening there. But there was really so the main point was that there were nice road approach, and there had what was the most important, that was the cooperation of different players within that field. And we could even show that the companies, they saved money with that organization. And also the processes of working and managing these whole things. And here is my proposal for a program, and I will tell you that this hasn't been tested scientifically, so that this whole program had been, but as Ivan Steenstra showed that when you are looking for systematic reviews and comparative studies, you hardly will find, but these ideas, they are very similar. You can find evidence for all of those, although I haven't done a systematic review on those items that similar what has done here in Toronto in Institute of Work and Health about those 7 principles for return to work, that they're based on research and also on common sense. And it covers ergonomics, safety, health promotion, support for disabled workers, development of treatment and rehabilitation, and promotion of attitudes. And first I will go to ergonomics. And by ergonomics I mean technical solutions. It means tools, equipment, methods, environment, organization of the work, but also the solution for the whole working system. And also what comes there within is promotion of competence. And we also did one study about material manual handling, a systematic review done by one of my colleagues as a first author, Esa-Pekka Martimo. And we collected on those studies that had used some kind of equipment or training for manual material handling. And the result of that review was that there were altogether more than, I think, 5,000 workers or patients included, and the main result was that just by training it's not possible to prevent low back pain. But okay, some of my colleagues said that okay, should we now start speaking against those advising and training for manual material handling? I said no, because it's by that advice the people who are doing manual material handling, they are at risk for injuries, and so they have to know those risks for injuries. And the main challenge here is the management and leadership. And so it means that those who are the main players here, they are from the big bosses who defined in the enterprises that what's happening there, because they are key persons. If they don't agree, nothing will happen. But then also for the workers there, and also for the foremen. This is the common play for those, and as I mentioned, in Finland, occupational health is one of the key players, and I showed the same picture of the lectures for them there and asking them what's the role of occupational health there. And they are somehow astonished that if we don't have any role, but the role of occupational health is, of course, that they can give based on their knowledge of patients, and so they can give hints for the company that, okay, there you have, within those workstations, there you have problems, and you have to solve them, but they are not occupational health. People are, of course, not competent to solve the technical or organizational problems. Then comes the safety, and it's mainly prevention of accidental injuries. And one point here is that what we can say that is when we are looking in longitudinal studies, that what has predicted the current or past musculoskeletal disorders people have said that they had during the past months or the last year, they have been the previous musculoskeletal disorders. They are absolutely the strongest predictor. And then comes the question on that, what's the origin of those first incidents of musculoskeletal disorders? And my hypothesis is that, but I haven't seen studies on this, on epidemiology of accidents, accident prevention, and musculoskeletal disorders. I tried to find those, but I haven't found that. I have done it myself, but I'm ready to bet that there will be some kind of association between those prevention of accidents. Once you get an accident, then you are more vulnerable for musculoskeletal disorders in the future. And it can also be the nearby accidents. It means that those situations when we slip but we don't have broken bones or things like that, but still even those, within those situations the biomechanical forces are high enough to cause changes in the body. And again here, this is again the co-play. There is those at the workplace, and there is also the occupational health or health is that can show the statistics about the accidents to the workplace to look for more on those. Then comes health promotion, and it means that what I have seen is that general fitness is important to us. As I mentioned already, that there are weekly we can read new studies on benefits of fitness and fitness training, and even those that it means changing of our habits. Also, for example, that's very common, and what you have done or here during your workday here, you have been sitting for too long times. So please raise up again. Please raise up. And because while you are raising up, you will give impulses for your body so that to reduce the risks of inactivity. So please, you can sit down. So it's not much, but as you can see that you were hesitating, many of yours, that you are so habituated, and we are so habituated to be sitting, and for example, in keeping standing there sometimes, or keeping a meeting while you are standing or even walking is possible. Then there comes, of course, you have to keep in mind that in exercising there are risks for accidental injuries, and there are some games that are more risky than the others. And as we first promoted this on the 90s about this basic idea for increasing the fitness, then it was the time when AIDS came, and there was the discussions about safety sex, and one of our researchers proposed that should we have also safety exercises. Then are these general risk factors: obesity, smoking, alcohol, narcotics. And today we know even more and more about the importance of good sleep. And this is probably more common, this health promotion between the health personnel and workers, but still I see that there is the company can have also a big role. For example, for preventing of obesity is that the serving meals in catering, serving good healthy meals for smoking, non-smoking companies, and so on. Then comes the support of disabled workers, and as showed as my last slide there, that our workability is not always the same, and also it's not an on-off phenomenon. So it is one option is to reduce the workload during periods of symptoms and recovery from a disease, and there are options that just to avoid those, for example, manual material handling tasks sometimes, or to make planned work to be done shortened, adapting the working hours to reduce the load. And there, in Finland, we have, by law, it's today possible to have so-called part-time sick leave. Is that also in Canada? Yes. And we made a randomized comparative trial on that. So it was from the first days of sick leave, we randomized people before this was by law benefit or option for all people. We had special arrangement on it, and we randomized it so that they were selected so that people who still had the work ability, so that they were estimated to have at least half of their work ability left. And there were limitations in certain tasks, but still it was so that they were not able to do the whole day work. We randomized them, and within that trial we showed that those people who were on part-time sick leave, they returned to ordinary work, so permanently to the ordinary work, earlier than those who had been on whole-time sick leave. And one of my explanations comes from that adaptation model I showed you, that if you are totally on sick leave and you are not doing anything, then you will adapt quite quickly on that position. But when you are doing something, you are training your body and your skills, you are more able to come earlier back to work. And also when we're looking for the total time people were out of work, all the sick leaves during the follow-up year, it was much less for that part-time sick leave group. In UK, the same idea is with this so-called fit note that has, so that the general practitioners and occupational health doctors, they have to make an estimate on, not on work disability, but about the fitness to work. And this is again means that there is need for different players to understand what's going on there. Then comes the development of treatment and rehabilitation. And we have in Finland, and you have in Canada also, for those good practice guidelines. But it's not enough to just to have those general guidelines. It's like laws, so that you need to have good processes to fulfill those guidelines. And it means good cooperation between the healthcare providers, and also that this hasn't been so common that into medical practice that you have to think and combine the medical practice to the workplace. And so with this cooperation between the different healthcare with providers, but also with the workplace. And finally, this promotion of attitudes, it's about safety, about ergonomics, beliefs on diseases. For example, a common belief is that, okay, if you are hurting somewhere, then you have to rest. And we know today that it's even that one of the studies I made, and that was repeated later in other countries as well, and what was that for women in office work who had plenty of neck shoulder pain, we tried a training program, and that was really a success. It was effective for those, and then it was repeated later in Denmark at least, and also in Sweden. What they showed there, that after starting that training program, it is after the first during the first months after these training sessions, you will feel more pain than while starting that program. And it's of course important to tell people that, okay, it's not dangerous, that pain, but if you will go on with that program, it will relieve after that. And then of course this health behavior issue that seemed to be one of the biggest problems in Western inactivity, overeating, narcotics, and so on. And so I propose that you are free to try this kind of program.
Hi, I'm Terry Aversa, a health and safety officer at the Ontario Public Service Employees Union. You know the slide you had up with the numbers 1 to 6, and then you went through them. I just wanted you to comment about if there's any possible desired order of them. The reason I ask this is because just like bell-bottom pants was really big when I was very young, and big hair was big in the 80s. The big fad in Ontario right now is culture. If I can improve the culture, everything's going to be better. And, you know, it doesn't resonate that well with workers because you have to see an action to actually be impressed and to move forward with thinking that things are going to get better. So I just wanted to hear your comment because I was thinking when I looked at your list of 6, the number 6 incorporates maybe culture, like the attitudes, right? So I just wondered if you numbered them because of any particular order or how you see changing the culture in the absence of any kind of actual change that's visible about the possibilities of that working. Because that's where Ontario is right now, really pushing this culture thing.
I think you have that it's also the last slide where I was about promoting the attitudes, but it's anyhow changing the culture is very difficult, and it means that you have also keep in mind that changing a workplace culture is also it takes time, and for example within that good example I told about changing the whole system and cooperation in a Finnish company, public house company. It was after the second year of activities they could see that there were some real changes. So and then comes of course the paradox of today that when you are living on quartiles, economic quartiles, you don't plan for something that will be after 2 years.
Any other questions?
I'm James Bryan with Magna International. You mentioned competency as an individual risk factor and an opportunity to significantly improve things. How would you actually evaluate competency with regard to musculoskeletal risk? Is it an individual's ability to make rate, or what actually are we looking at with this competency idea?
I think for me it's more or less or highly related to the work tasks. So that if you are the way you are working, taking additional risks, and what has been shown that we as individuals we can for example with manual material handling, one of there have been advising of manual material handling, okay, you should use more your knees and lower limbs and don't bend forward or things like that. But the first advice is that think that can you make the handling without using your body and your back. That's the basic idea there. And I haven't seen any exact measures of those because they are so highly dependent on the technology and working. But it's also the way that you might find from elderly workers who have done the same work that they have that tacit knowledge and follow up those that how are they doing the things. That may be one hint to find good practices.
Thank you.
Just had a question for clarification in your presentation. Maybe I'm reading too much into it, but in your slides you have a graphic of a nurse or a health professional wearing a stethoscope in all of your slides, and how that health professional interacts with other parts of, I guess, a company, other employees. Does that health professional represent employees within the company that are health-minded, or professionals that are external from the company?
Now I'm speaking from the Finnish, the ways in Finland. And in Finland it's so that each workplace should have medical advisors in occupational health. They are not hired today. They were big companies had own medical stations in the until middle or end of the past decade. But today there are more and more. There are health providers, there are individual companies that are giving advice. But what's important for those, and that's one of the problems, is that when they were part of the enterprise, they knew that what's done there in the enterprise. They knew the risk and they knew the people who are doing those. But today it's not anymore. They don't have the medical people there and health people. They don't have that knowledge anymore. But it has been the economical solutions for workplaces, because even though that occupational health has been obligatory and it has been commonly accepted, but now today the workplaces are asking more and more, what's the benefit of those activities? And that has led to competition, and of course it has meant also that people who are skilled or not skilled, there is a big variation today in Finland within those.
Any last questions? You have a chance of further questions in the panel, so thank you very much.